So most of our patients are in monotherapy. They're in orthokeratology, they're in SLS, they're in my site only. Hey, but high five. But about 15 to 20% of the time, I do combination treatment. And by the way, that's my son. We're at the park outside my son's elementary school. My son is actually a case of a patient that is in combo treatment. Oh, okay. So we started him atropine when he was 4 years old.
Wow.
And then, unfortunately, he still progressed quickly. Wow. And then we had him on, when he was like plano -1/4, we had him on my site. Mm-hmm. And then he still progressed super fast.
Wow.
And then when he was about a -1.5 or so, we switched to Ortho-K. So now he's been Ortho-K. So he progressed from 0 to 1.5 to now -2 quickly within a year or two, even on atropine and my site.
Well, how myopic are you?
I'm -9.
Oh, wow.
And then,
yeah.
and so he still, and then he was -2. Then when you switch him to Ortho-K, and since on Ortho-K, he's actually been like flat, much better.
Stable. Yeah.
So my anecdotal experience has been Ortho-K is a little bit better than almost anything, right? And so not that now the studies might show otherwise, but like I'm just saying, in my case, like it's gone really well. So every case is different. Mm-hmm. My main point of my main point here is essentially that there are patients that you might want to combo, you might want to switch, and depending on how things are going. So if things are not going really well with one, I'm not saying combo everyone, but you might want to just switch from that to something else. So let's say the patient's on Ortho-K. I've had this opposite happen. They're on Ortho-K progressing quickly. I switched them to my side, and they did better. I've had patients who are on, atropine only, and then they progress, and then we switch them to Ortho-K. They did much better. Like, it goes both ways. And so, in general, though, that's the reason why you have to have a frequent follow-up.
Right.
How are things going? If things are not going well, like consider changing it to a different type of treatment or comboing with something with atropine. In general, the optical interventions, Ortho-K, SLS, contact lenses, whatever, they're optical. Yeah. Then there's pharmaceutical, which is the atropine. In my opinion, those are probably two different buckets. Mm-hmm. But comboing them together for some patients is very helpful.
Mm-hmm, mm-hmm. Yeah, I've seen that also in our clinic where a patient will start off with MiSight or natural view multifocal because the soft lens, the idea of putting a soft lens in their eye is just better received by the parent and the child. They're like, do you want to try a soft lens or a hard lens? They're like, let's try the soft lens first. So they might wear that for 3 or 6 months and we'll follow up with them. And then eventually, we call it graduating. They'll graduate over to an Ortho-K lens. They'll start wearing Ortho-K lens. Yep. A lot of the skills that they learn from putting on a soft lens is transferable to the hard lens, to the nighttime wearing lens. Yeah. And then the idea of wearing a hard lens isn't as big of a jump. They're like, okay, I've worn the soft lens for 6 months successfully. Let's go ahead and start wearing a hard lens at nighttime. And we've had a lot of success with that, just switching patients from a soft lens and then 6 months later switching them to a hard lens. Because to your point, I do see cases where it still progresses a little bit faster than we would like. Like and it does follow like a lot of the axial length studies that are showing 59% control of refractive error. But if the Ortho-K lens is designed correctly, sometimes we see 70, 80, 90, even complete stability of the axial length in a 9-year-old. I've seen that with Ortho-K lenses.
My anecdotal experience, and I'm not being paid to say this, honestly, I think Ortho-K is probably one of the best, if not the best, way to do myopia control on most kids. Now, of course, that's because I was originating an Ortho-K guy, so I'm a little bit biased, but it's just gone so well that it's kind of one of my go-tos. Even though I have SLS, even though I have MiSight, even though I have atropine, still one of my top ones. Yeah. I've done over 1,000 cases of Ortho-K, and my experience, and maybe you share this too, is that when I train kids on insertion removal or soft lens, was training kids on insertion removal of an orthokeratology lens. Mm-hmm. It's much easier. I was going to give them a plunger. It's much easier if someone insert the Ortho-K lens than it is to insert the bigger, floppier soft kind lens. Yeah. It's also easier to take out the Ortho-K lens with a plunger than it is to take out and pinch off the soft kind lens. So my experience, INR goes easier. Mm-hmm. When I ask my son, who's done both, when I ask him, hey, which one? And I've asked him this multiple times because I live with the guy. Like, which one do you like better? You've done both. Like, which one's easier to take in and out? Which one do you prefer in terms of visually? Yeah. And this is what I've heard from my patients as well. He loves the Ortho-K lens. He's like, I see better. Wow. And it's also easier to take in and out. And I don't have to work, anything at school. Right. And obviously compliance of it is much better because I can control it at home. Yeah. With soft lens, it's something that he can take out. He's got to take it out. So so his Ortho-K lens is all day long. And so soft lenses, I've had kids before SLS was around they'd wear the MiSight lens, and they go home, they take them out because their eyes get dry. And then now they're not being treated for like the 4 hours where they're, having dinner, right, and doing homework, which is not preferable. Whereas Ortho-K, you can't just take it out in the middle of the day. It's either you skip the night or not, but as long as you wear it all night, you're good to go.
I think it's great that we have so many more tools in the toolbox that we have now in order to slow down myopia.
Yeah.
Because like with the MiSight lens, I mean, it does get dry, and because the oxygen permeability for that material is not good, it's based on the ProClear brand, right, and the contact lens material, but also for the natural view multifocal, I mean, that's based on it's Edafilcon A. It's the same as AccuView 2. And so it's not very oxygen permeable.
Sure, yeah.
So it's kind of like having to find a balance between, well, the oxygen permeability and the health of the eye versus the myopia control. So there's always some trade-offs, but having these extra, like STELS, for example, to add that onto the toolbox, if somebody does suffer from oxygen permeability issues with their cornea, then we could put them on STELS and still get control. Because one of the problems with it, if they do have an eyelid infection, for example, and they have to stop wearing the Ortho-K lens for a week and use oxyfloxacin until their eyes heal, what do we do in the meantime?
Sure.
Yeah. They wear their glasses. But the best thing to do would be to wear their STELS glasses during that time.
Good point. Yeah. And, we talk about STELS since it's the only one that's FDA authorized, but, if for the future who is watching this video, still, I'm prescribing DIMS and prescribing STELS, or all of the above.
All of the above, yeah.
But,
that's an option.
Yeah, MyoSmart. But yeah, so I guess my question to you is this. It's, so let's say they're on a soft multifocal, like MiSight.
Mm-hmm.
Would you recommend essentially every single one of those patients, there might be some exceptions, but the vast majority of the time, if they're wearing soft multifocal contact lenses, when they take out the lens, should they be wearing a lens like STELS or MyoSmart? Or should they or you prescribe most of the time single vision afterwards?
Yeah, it's a great question. I feel like when we prescribe single vision, it is doing the patient a disservice because we understand the science behind it, and it's about peripheral myopic defocus. We want that peripheral myopic defocus where the peripheral light rays are in front of the retina, and that's what slows down myopia. That's what does not send the signal for the eyeball to continue elongating at a faster rate.
Yeah.
So by prescribing regular single vision lenses, and if they're reading up close with it, that is putting that light behind the retina and elongating the retina. So still, I always feel like I'm doing myself a disservice or doing the patient a disservice. Like it's kind of contrary to what we want, right? And so then I always kind of like, I really don't know what to do in that case.
Mm-hmm.
But now that STELS and other myopic spectacle lenses are available to us, I will know what the right thing to do is, which is to recommend that the patient will get STELS, prescribe that along with MiSight, along with it, because it doesn't have to be or, it could be and, right? They could wear MiSight and STELS, not at the same time, but like they could be wearing it at different times. If they have an eye infection, they could have STELS as a backup pair of glasses.
I'm with you, 100% agree. I think, like, sometimes I see advertisements from doctors where it's almost a FTC violation where they say, hey, do Ortho-K, throw away your glasses. That's actually technically almost borderline illegal to say that in an advertisement because Orthokeratology, for instance, is only approved for the temporary reduction of myopia, right, in theory. So what that means is that you can't just be advertising that they can throw away their glasses because in theory what could happen is they can stop wearing the Ortho-K lenses and they need glasses again. So that's why some doctors might get in trouble with, not that they would with the FTC, because it's just, in theory, no one can call them out. But that's why we've been very careful. In our messaging to the patients, we don't say throw away your glasses because you're an Ortho-K. We say we're doing Ortho-K to control myopia. By the way, there are some times where Johnny still needs a pair of glasses.
Right.
It's not going to eliminate his need for glasses. He might have to go to camp and not wear the lenses. And then when he does his Ortho-K lenses, then I want him in glasses. Right. And to your point, if they're in Ortho-K, or they're certainly with atropine, or certainly with with soft multifocal, a lot of time, the vast majority of the time, I'm going to just prescribe them a lens like STELS to have in addition.
STELS is definitely something very beneficial, especially if a patient is just gradually getting into Ortho-K, meaning it's going to take a few days for the cornea to reshape. What lenses do you recommend that they wear during that time, right? If we prescribe STELS during that week that they're wearing Ortho-K lenses, let's say they're -5, but then like after the first day of wearing Ortho-K, they're -250, they still need something to go to school with. But do you advise them to wear their -5 spectacle lenses, or do you prescribe STELS, where it's still -5 so you can see very well, but at least there's that peripheral defocus so that they could not advance their myopia during those times?
Oh, that's a good question. So that's a nuanced question, but this is what I would do. So unfortunately, because let's say they're -5, and they get Ortho-K, right? I would prescribe the -5 so because then there might be times they might discontinue altogether. You know, they might wash out for 2, 3, 4 days when they go to camp. Then they want to have a -5. Now in the interim period though, let's say they're 250, then a -1, then planner, right? Usually I would just actually go with like I would just give them a loaner pair of -250, either single vision. You know, you actually just buy point. We have loaner glasses that we hand out. The patient literally just, we load it to them. They bring it back the next day because they're not -250 anymore, right? Or the next couple days later. And they've been single vision, but I actually might update my loaner set. I'm literally thinking about this right now as we're talking. I might update, maybe I'll have a -1 Celeste, 2, 3, 4, 5 Celeste in my loaner set.
Wow.
And so if they're transitioning for that week even, maybe I'll be loading that out. Yeah, wow. I haven't done that yet.
Definitely leveling up the game.
Yeah, right now we've just been doing single vision. But maybe
that's because Celeste was not available.
Yeah.
You know, like a couple of weeks ago. But now that it's available, the loaner pairs, not only is that a sample for the patient to try, but it also slows down myopia.
Yeah.
With that loaner pair.
Oh yeah. If we believe, which I believe, that every day a child is not, every day a patient is left untreated, is they're gonna progress. Like I think 98% of the time, that -1 8-year-old kid is gonna progress. We all have seen it in clinic. Obviously, there's no debate there. Yeah. The data shows that they progress the vast majority of the time. Right. So if you even wait, if you miss a day, you can lose vision permanently, which is I don't want to scare a mom, but that's actually what's happening, right? And so if that's the case, if we believe that's true, it's like letting the patient who's a 30 IOP patient.
Exactly.
You know that they're 30. Like, shouldn't you
something about it in the office, right?
Yeah.
Slow it down.
Yeah, maybe you should.
Lower the IOP in the office before you discharge them.
Exactly. You probably should do something, yeah. Now, it's tricky because using that same analogy, let's say they're getting SLT in like a month. Are you going to put them on drops for the next month? Maybe.
Yeah.
Right?
Just to protect their eye.
Yes.
In case,
maybe.
Right?
But of course, they might want them off the drops because like you want to be off prostaglandins maybe because of inflammation. But that's...
right?
But yes, in general, let's say, let's another example. Like let's say you had to do glaucoma surgery and you were 6 months out. Yeah, you probably want to do something if you were 35 IOP until then. You know, because let's say you can't get into surgery because you live in Kentucky and the surgeon's booked out till 6 months. You know, who knows, right?
Even just a few weeks or a few months. Like if using the glaucoma analogy, if somebody was walking around with a 30 IOP, even for like a week, we'd be a little bit cautious about that, right?
Yeah.
So if they're going to do a lot of hyperopic defocus, they're going to be looking at their phone or their watch, like their Apple Watch this closely all the time. You know,
you might as well have your loaner pair of glasses in Stellas too. Oh, fair. Let's do it.
Right? It's scary. If they're doing this for like a week, that could cause their progression to accelerate.
Yeah. You know, there's and right now it's as we're shooting this, it's actually November. So what's gonna happen in the winter?
Oh yeah, it accelerates faster.
Yeah, exactly.
Yeah, I do see that too. Yeah.
Have you seen that a lot?
I have.
Yeah.
So, for all the seasons, managing myopia, like over the 6 or 7 years, I do see faster progression of myopia during the winter time than in the summertime.
There's actually data on it too. So it's been our anecdotal experience in clinic, but there's now papers about faster progression in the wintertime than it has in the summer. So there's actually now...
I mean, it just rained here last week and everyone was indoors, looking for things like indoors to do, right? Like, it's raining outside, what should we do indoors? But I'm just thinking about myopia the whole time. I know like maybe other parents don't think about myopia, but what can I do that my child will not be progressing their myopia? And so we decided to go like to IKEA, you know? Indoors, and they could like play around IKEA, live far away. But I didn't want them to just be at home looking at their screens all day. Yeah, absolutely. Yeah, that's what the data shows. They've done studies where they have kids like in Australia who used to live in China and they got more or less screen time. They've had studies with identical twins as well, and they find that the outdoor activity, big difference. Yeah. So let's see, where should we take this conversation next? I have examples. I have like a real case example of somebody that she's like a 13-year-old now, but I started treating him with first MiSight for a year, and then he switched over to Ortho-K, and we're getting better results with Ortho-K.
Let's talk about the case.
Let's talk about it, yeah.
Okay, so how old was the patient for Saya? What was their prescription? Axial length approximately?
I first saw the patient when he was 11 years old. He was referred to me by another provider for myopia management. He wasn't wearing any glasses or anything. He was a -1 in one eye and -350 in the other eye.
Wow, so nicer. 350, 1.
Yes. And so his biggest concern, he has real anxiety about this. And his parents are really smart. His dad works for Google, and he found me and he's like, okay, can you help me slow down my child's myopia because he wants to do laser eye surgery in the future because the dad had laser eye surgery done and that's the goal.
Sure.
So I'm like, well, okay, it's safest to do laser eye surgery if we can keep your myopia under -6, -5 to -6. If it goes beyond -6, then you might not be a great candidate for LASIK because we have to remove too much corneal tissue from your eye. So maybe like ICL will be a better one in the future if it's beyond -6. But also if it's -6, there's a higher risk for other type of diseases of the eye, like glaucoma, cataracts, posterior subcapsular cataracts, and retinal detachments. And so this child had anxiety about his myopia. He really didn't want it to advance anymore. And he's very numbers driven too. So I go over the chart with him and see what his axial length is. We get a baseline measurement. And every 3 or 4 months when he comes back for his Ortho-K progress check, we're checking his axial length. And he is just kind of like always anxious to know what it is. But what's really good is just mapping it out on the chart and showing him before he even got started what his axial length would be at the time he is 17, 18 when he could get LASIK, legally. But, we want to see at least 2 years of stable vision before he does LASIK. But at least 18 years old, what it would be for his myopia progression if he were to start on Ortho-K at 11 years old versus not. Mm-hmm. And already at a -350, he would have progressed similar to what his dad is, which is -8 to 850, if he didn't do any kind of myopia intervention.
Yeah, makes sense.
But because we did do it, and now it's been 2 years, we see it just level off. Mm-hmm. And with Ortho-K, it only progressed by a quarter diopter.
Nice.
It progressed by about 0.01 millimeters. Yeah.
Oh, so completely stable axial length.
That's very stable.
Yeah.
So if it continues in this way, you're going to end up being a -450 at most when you're in 18 or 19. So that's when you could do it. And you could just see him like breathe a sigh of relief.
Yeah. It
was just,
I was happy.
Yeah.
Yeah.
And so we started off with my sight. We weren't getting that great of a result because he had some eyelids, he was getting dry eyes.
Yeah.
And so then when we switched over within a few months to Ortho-K, he said it's more comfortable. He sees better with it, but at the same time, when we go over the chart with him, that's when he's like, he could see the results happening in real time, every visit.
Yeah.
And he's looking forward to getting, LASIK in the future, which I believe because of Ortho-K, he will be able to and not have to do any kind of like other type of surgeries that, could, like ICL, for example. Yeah,
I love it. It's a good case. Let's talk about anisometropia and myopia management. So patients sometimes is like a -350 in one eye, -1 in the other. Or what if they're like -3 in one eye and plano in the other eye?
Yeah.
I see multiple like this. Mm-hmm. It's a interesting conundrum as a doctor. There's not one way to do it. I'm curious how you treat that patient. Essentially, let's say, let's create the profile. This is a patient who is, let's say, an Asian female.
Okay.
Both parents are myopic.
Yeah.
You spend a little bit of time on screens, of course. And let's just say they're 8 years old. Plano in one eye, -350 in the other eye. Are you treating both eyes? And if you are, why, what are you doing most of the time? And then if not, why just one eye?
Right.
Yeah.
And so studies show that each diopter of progression increases the risk for ocular diseases down the line by 40%. Like it's our mission is to slow down myopia, and every diopter counts.
That's right. Yeah. There's the Bullimore study, right? Every diopter increases the risk for myopic maculopathy by about 40%.
Yes.
Yeah. That's right.
So if the parents have high myopia, the parents understand one eye is just growing at a lot faster of a rate.
Yep.
But it's because every diopter counts, we would want to start treating the other eye prophylactically, or just even like starting with atropine.
Sure.
So like the eye that's plano and the -350, we'll start with atropine for both eyes. And then we can use optical treatments for like STELS or also MySight. We would do that for one eye, but monitor the other eye very closely. Mm-hmm. If we start to see a little bit of myopia, then we start prescribing multifocal soft classic lens in that eye as well.
Sure.
But yeah, we'll just follow up very closely. We'll start with atropine for both eyes, and we'll do an optical solution for the myopic eye.
Yep.
And once we start to see a little bit of myopia in the other eye, then we would treat that eye as well, whether it be Ortho-K or multifocal soft contact lenses or now STELS.
I love it. Yeah. High anisometropia is not a absolute contraindication, but it's a relative one for glasses, because the image size is different. Yeah. So a lot of times, most of the time for that plano -3, -4 patient, I'm going to do a contact lens in the other eye, right? It's going to be Ortho-K or a soft multifocal. Yeah. And then, I like the fact that you're treating atropine on the plano eye because it's essentially pre-myopia. You're treating pre-myopia. Yeah, maybe not refractively, it's minus, quarter, minus 50 yet, but we know the future for an 8-year-old who's plano, like with the other eye myopic, with myopic parents, it's probably inevitable. And it's nice to treat both eyes.
Yeah, and one way is to tell the student or the child, hey, like your right eye is clear, but your left eye is really blurry.
Yeah.
You use this Ortho-K lens at nighttime for your left eye because we don't want your right eye to be the same as your left eye. Like imagine if your right eye was as blurry as your left eye.
Oh, you mean use the eye drop?
Eye drop for both.
Yeah.
You're talking about like using Ortho-K lens in one eye.
Yes.
So I think it from the perspective of the child,
Yeah.
they would be thinking, why am I putting this hard lens in my eye? And then, binocularly, they're going to see the same.
Sure.
Like, why I take it out in the morning and I don't really see any better. Why am I doing that?
So you're saying the left eye's plano?
Yeah.
Right.
Either eye. One's plano and one's like minus 350.
Okay.
But the child's only putting the Ortho-K lens in one eye.
Sure, yeah. On the 350 eye.
Right, on the 350 eye.
Yeah.
To see better with that eye.
Sure, yeah.
Binocularly, they already see 20/20. So how do you encourage that child to put on the lens at nighttime?
I see what you're saying. Yeah. It's a discussion with the child and the parent.
Yeah.
Of like, hey, like, we don't want your other eye. First of all, yeah, so you're basically saying that patient who's plano minus 3, with both eyes open, they've been essentially using the dominant eye, the plano eye,
Yeah.
and seeing 20/20 where they're pretty happy-ish.
Yeah.
Yeah, I would just say, like, you better depth perception, better able to play sports.
That's true.
You can see better with both eyes, 2 eyes are better than one. To the mom and dad, say, hey, we want to control axial length on that eye as well, on the right eye,
From your experience, like what percentage, it's just a matter of time that the other eye becomes myopic.
amount of time.
Yeah.
Yeah.
And I've seen that time and time again. Like the one eye just progresses first, and then the other eye eventually becomes nearsighted.
Yeah.
So they already have the skill of using an Ortho-K in one eye. Then once the other eye becomes myopic, we design the custom design an Ortho-K lens for the other eye.
Yep.
And they know how to use it. It's very easy to transition from one Ortho-K to two Ortho-K lenses.
Right, you have a good point. So unfortunately, that plano eye will eventually become -1, let's say.
Yeah.
Unfortunately, or hopefully not.
Yeah.
But yeah, if they will, that's nice to be trained how to do that. So a lot of times what I've done is it's tricky with doing orthokeratology. The reason why is this: if the patient's like a minus 0.25 or minus 50 or minus 0.75. I don't get as much of that molding with Ortho-K that I would like to get that nice plus power, right? And so for a lot of these patients who are like, minus half, I like soft multifocals. And so a patient who, let's say they're plano 3, knowing the future might be, 3 minus 50, I might do soft multifocals instead of Ortho-K. The reason why is because then I'm going to do soft multifocals in both eyes. Whereas if I did Ortho-K, I'm probably not going to do Ortho-K at a minus 0.25
Right.
or minus 50, minus 75 even. I might not. And so it'd be weird to do soft multifocals in that eye and then Ortho-K in the other eye.
Yeah.
Since I know the future, a lot of times I opt for the soft multifocal first. But, at the same time, guess what? So I've had, on the other side, I've had mom and dad, let's say I've had patients who come from China.
Yeah.
And they know about Ortho-K from all their friends in China that are doing it. And they're like, no, we want to do Ortho-K in that right eye.
Yeah.
Even though I might say, okay, well, blah, blah, blah about the minus 50 in the left eye, 100 Ortho-K. Guess what I do? Yeah, I'm not sure,
You do.
because sometimes the mom and dad just win.
Oh, okay.
And so and I'm willing to do it,
Okay.
and so, we'll figure out later on if we decide to do Ortho-K in that minus 50 eye, or we decide to just do a soft lens in that left eye.
But it's better than nothing.
Then exactly. So,
Yeah.
so
Harming the patient.
So exactly. Sometimes we get caught up in let's say, I'll give you an example. Let's say for this patient, I really want to do Ortho-K. Clinically speaking, what if I believe in my heart that Ortho-K is the best for this patient in particular? Let's say the patient's like a minus 4, and they're progressing quickly, and they're 13 years. Let's say they're 12 years old, and they're ready for it.
Yeah.
Maturity-wise for contact lenses, but the mom's like, we are not doing that. We are not doing it for XYZ reasons, and the kid is freaked out about touching their eye. I'm not gonna force them to wear contacts if they're freaking out about touching their eye. I'm like, no problem. We have other things in our toolbox. We can do a SLS lens. We do atropine. It's a conversation. And so something is usually bad. Nothing. And the doctor has to work with the patient.
Yeah. So it's great to have SLS because it just adds another option, another choice, another a way to slow down myopia. So now we're like the United States and the other countries. We have the same tools in the toolbox.
Right? Exactly. Out of curiosity, so let's talk a little bit about global fees versus a la carte. So there are certainly doctors that say, hey, we'll sell them glasses for whatever.
Uh-huh.
Let's just ballpark it. Let's say the pair of lenses and frame, let's just say it's $600.
Okay.
Let's just say that's what their motto is. And then they either prescribe $600 glasses and say, see you later, see you next year. Like, I'll give you an example. When I was talking to a colleague in Europe, and what he says is that spectacle lenses in Europe has made it so more doctors are giving kids myopia spectacle control glasses, which is great.
Yeah.
At the same time, he believes the standard of care has dropped dramatically because some kids are getting the glasses and they do no follow-up with the doctor, which we don't like. We don't like when the kid has no follow-up with the doctor because then they can progress without better intervention, right?
Yeah.
So my question to you is, are you charging a la carte every visit for all the follow-ups, or are you saying, you know what, I've got a myopia program to sign up for it, it's going to be X amount of dollars, and then sign up for the program, which includes glasses and then all visits.
Right.
What's your model?
Well, our model is a global fee.
Yep.
The way that we explain it is very similar to how orthodontists explain it, where we're not really paying for the rubber bands and the brackets, we're paying for the results, the outcome of straight teeth. So we explain that to parents, we're paying for the global fee and the outcome of slower myopia, less myopia in the future than they would otherwise have. And so whether it be any of the tools in the toolbox, Ortho-K or MySight or STELS, any or atropine even, like any of those things that we do to slow down myopia, it's all one global fee. And we don't charge a la carte for office visits. In fact, we even let patients that have any type of anterior segment issue come in, whether it be a sty. If they're on the program, they're a VIP patient, and we take care of them. We want to make sure that they're undergoing their treatment with their myopia correcting solution, but at the same time, we want to take care of their eye too, because that's what we're here for, to take care of their entire vision for the rest of their life. And that involves that we don't want them to feel like, oh, I don't want to go to see this doctor because I have to pay out of pocket for this visit, right?
Yeah.
And so if they have any issues, we tell them you can come back because you are a VIP patient. And we do want to see them because every time they come in, we do an axial length measurement.
Love it. It's like going to a Las Vegas buffet and you're like, I'm going to go to Bacchanal or the Bellagio buffet. It's going to be $80 for the buffet. Yeah. But then you're there and you're like, hey, I could just get whatever I want.
Yeah.
Right. This is kind of nice. Like, so you don't, for that, maybe some offices, like they want to build a red eye visit.
All right.
Because like, the red eye is caused by this, not that. The patient says it's caused by contact lens. You're saying, no, it's caused by this. It gets into like, conversation about fees.
Right.
You guys just be like, we'll take care of little Johnny. Uh-huh. He's in our global fee. Unlimited visits.
Unlimited visits, yeah.
Fair, I like it. Yeah.
And we found that patients, they appreciate that too.
Yeah.
Because then they don't have to call and say, oh, what's gonna be if I do come in and like, my little Johnny's eyes are red right now. We're not sure if it's Ortho-K related, and the doctor's not sure too until we see them.
Yeah.
It could be allergic conjunctivitis, or it could be that the Ortho-K lens has a scratch on it.
Sure.
So either way, we want to check the eye, but we don't want the patient to not come in because they're worried about having to pay a fee for the office visit. So we just build it in, a global fee. So if they're wearing Ortho-K, if we're treating them for myopia, it's all just one fee, and we take care of them for that period of time.
Love it. Yep, I agree that I believe that that's the better model. Mm-hmm. Well, the reason why is I believe it delivers better patient care. Mm-hmm. The patient is actually going to show up for the follow-up visits because they're not being nickel and dime for the follow-ups, which means they're more likely to show up. Yeah. If they show up to the follow-up visits, they're more likely to stay on track. Mm-hmm. They're more likely to transition to the right treatment if it's not going well. It helps us check in compliance, helps us check axial length, helps us modify things when they're going off the rails.
Right.
Yeah.
And patients understand and the parents know that we're on their side, that we're all on the same team.
Yeah.
And so we do have a very high renewal rate in terms of patients like renewing their Ortho-K programs for year to year.
Almost everyone.
Almost everyone.
Yeah, that's my experience.
We show them it's working. The parents go, I'm so glad. I had a parent tell me this week, I am so glad that we are doing this. And she's talking about Ortho-K.
Yeah.
We're so glad that we signed her up or we enrolled her in myopia management here in your office, because it is helping. And we show the data, we show the axial length measurement, how much it's slowing down, and just how much happier the child is.
Yeah, they have a better future. Mm-hmm. One thing we do is we have such a cool job.
Yeah,
like we help children have better vision for life, and it's a nice mission, and we live it and breathe it every day, and it's just rewarding to be an optometrist when you got to do that.
It is, yeah. So like helping parents that also have anxiety, because it's usually the parents that are in the medical field or that they have the really high myopia themselves.
Yeah.
That are the more anxious one coming in.
Yeah.
The child's just like, oh yeah, I'm chill, I'm here. First eye exam, I can see okay, but they're like a -3 or -2.
Yeah, the kid doesn't care. They're like a -2. Come on, but kid, like it's kind of blurry.
Right. That totally happens. Like a 9-year-old, I saw a patient who was 9, plays tennis, but he's a -2.
Yeah.
And the parents tell me that he's a really good tennis player. Like he could play the national championship.
Yeah.
For his age group.
Yeah.
And I'm like, how is he? I'm thinking in my head, how is he doing that as a -2 myopic patient, right?
Sure. Yeah.
And the parents are saying like he does really well in tennis. But I'm thinking, how much better would he do if he's fully corrected to see 20 feet away?
Yeah.
You know, he can actually see the serve of the ball coming.
That's crazy.
He's a -2 and he's a world-class tennis player.
Yeah.
So now that he's 12 years old, 13 years old, and he's been on Ortho-K, he's one of those patients that are just like stable axial length.
Nice.
It hasn't changed.
Yeah.
And it's the same design because of that for the past like 4 or 5 years.
Ah, easy.
It's crazy.
Nice.
And
dunk.
yeah, he's still a world-class tennis player.
Yeah. Yeah. You know, what you should do is take credit for it later on. Well, you know, it's because I'm a side doctor. Yeah. All right. Well, hey, great. Let's see what. Great conversation. Yeah. So let's wrap this up.
Okay.
So in closing, you know, obviously having all the tools has been helpful. Having STELS, and which is by the way FDA authorized and FDA approved. So be careful of your wording. Has been helpful for us. Like,
It has been, yeah.
my last question for you is: have you seen that having, you know, STELS now an option? Have you seen in your experience that it has decreased the Ortho-K market for you? Essentially, are less patients interested in Ortho-K now that STELS is available, or do you find that no, it's just made the whole pie bigger and everything is growing?
Yeah, I found that it has made the whole pie bigger.
Yeah.
That parents are more curious about myopia management now, and now that they're hearing about STELS, they now know that there's an option in the United States that is FDA authorized for myopia control with spectacle lenses. So it brings up the conversation.
Yeah.
And ultimately, we want what's best for little Johnny to slow down their myopia. So it has brought more awareness to the field, a lot more awareness into the conversations about myopia in the exam room. I don't find that it has cannibalized or reduced any of the Ortho-K or MiSight for that matter. It actually has expanded it because at the end of the day, it's not a either or. Like patients can be wearing, of course, like with STELS and atropine, but also they can have STELS as a loaner pair or spare pair while they're still using Ortho-K.
Love it.
So it's always like an add-on. It's an and not an or. And I haven't seen it reduce any of the numbers on Ortho-K. So it's a win-win for us.
That's what the data shows in China, Canada, Europe, is that the Ortho-K market and all the above is still increasing and growing. So the market share, like for instance in China, from like 2023 to 2024, what I saw was that the Ortho-K market still grew almost $1 billion. Wow. So it grew like, you know, let's say 20% or so.
Yeah.
And that's with the advent of spectacle lenses for years. And so, which is also growing tremendously quickly as well. So what we've seen is that all boats are rising.
Yeah.
It's just the fact that the real problem, the sin, is that the vast majority, as we're shooting this podcast, the vast majority of kids, like less than 5%, get any type of treatment at all. And then 95% get nothing. And so that's the problem. Right. And so whether if the whole boat just goes to 10%, 20%, everything would rise so fast. It could quadruple overnight. So that's our biggest problem, is lack of awareness.
Lack of awareness, yeah.
Yeah.
And just lack of bringing your kid to the doctor. I get a lot of times like, when should I bring my kid to the doctor?
Yeah.
Like any time, like now?
Yeah, 6 to 12 months for an eye exam, you know?
They're under your vision plan. You may bring them now to be checked.
Yeah. Great. Well, this has been a great conversation.
Likewise. Thank you for inviting me.
Appreciate the time.
Thanks, Dr. Mai. Great.